I'm Gail Wagner. Dan Ogola and I founded Matibabu back in 2004. And it is kind of amazing to both of us how far we've come. And I am an oncologist, fairly recently retired. So I am going to be the moderator of this meeting. We have also invited the First Lady of Kisumu, Dorothy Nyong'o, who is also the managing director of Africa Cancer Foundation and very knowledgeable, and Dr. Gladwell Kiarie, who is a wonderful oncologist, busy, kind. I'm just thrilled that she agreed to join us. For those of you who didn't know, she was Dr. Fred's doctor and is a really wonderful person. So with those introductions done, did I miss anything, Dorothy and Gladwell? I hope not.
No, you praised me too much. Thank you.
I think I will start with Dorothy because Dorothy has an unusual story. Dorothy is not a medically trained person, but has a very strong and personal interest in cancer. So Dorothy, could you explain how Africa Cancer Foundation came to be?
Thank you, Gail. So my story goes back to the year 2010, which is now 10 years ago, when we were actually in Malaysia for my daughter's graduation. And my husband had come a little bit after me, a few days after me, because he had stayed behind doing some work and getting some routine tests done. And when he came, he just told me he had some tests done and he'll be getting the results when he returns. So he left me behind, and he was, rushing back as usual to carry on with his duties. He was the Minister for Medical Services then, and that is Nyong'o. He's now Governor of Kisumu County. So a few days after he landed back in Kenya, I was still in Malaysia with my children. We were sightseeing. He sent me a text message that simply said, they found some cancerous cells. And my world went into a spin after that. But I didn't want to mess up the children's holiday. So I put on a brave face. I went down on my knees and prayed. I called him to explain. He didn't have very much information at that point. Finished with the holiday and came back to Kenya. And then we went to see the doctor to explain to us what was going on. To make a long story short, by December of that year, we found ourselves in San Francisco at the cancer center and proceeded to get radiation because he had prostate cancer. So we went through the radiation and in the process learned a whole lot about cancer. Cancer in general, prostate cancer specifically. We joined support groups. Just hearing people's journeys. We joined exercise groups to do all kinds of exercises. We attended webinars on nutrition, and it was just like our whole world got consumed by what we were learning about cancer. They had a very good resource center, the Helen Diller Resource Center, and we just absorbed so much. And what happened is that we thought to ourselves that all our education, all our exposure, we were this ignorant about cancer. What about the ordinary mwananchi, the ordinary person? What are they going through? What are the chances that they would even know what to do? So we decided that when we get back home, we would set up a foundation that would focus on educating people from the grassroots, just to know that one, cancer is real, two, how to even know, when you might be having cancer, three, to learn to go for regular checkups so that if cancer is detected, it's not a death sentence. So we set off with this in mind and came back, and by July that same year, that's 2011, Africa Cancer Foundation was launched. And we started off by developing materials, which we adapted from the US National Cancer Institute materials on various cancers. So we have 13 fact sheets on cancers. Then we had various booklets that we worked on chemotherapy, on radiation therapy, on nutrition, and a general one on what do you do if you're diagnosed with cancer. So we started giving out these materials to people who just wanted to know more, or people who had recently been diagnosed with cancer. And we went on to do research. Dan Ogola talked about it earlier. I will go into more detail maybe later on. But we then said, okay, apart from awareness, what else can we do? And we decided to embark on providing screening to the general public. People who under normal circumstances would not find themselves at a hospital to find out what's going on. So we were going around the country. In Kenya, we have been to 23 counties and screened over 26,000 people for the most common cancers, which are breast, cervix, and prostate. And then after that, we felt, okay, we need to go a step further. So we teamed up with Bridge to Health in Canada. They gave us a thermal coagulation machine, and we started to provide thermal ablation for women who had precancerous lesions. And so it's been almost a 10-year journey. We really thank God because Governor Nyong'o is now, a 10-year survivor, and he is very, very committed to the cause of cancer in Kisumu and in Kenya.
Oh, thank you, Dorothy. That's actually a very inspiring story, and obviously it's something very close to your heart. And you have done a lot in rural parts of Kenya, screening people that otherwise would not have been screened. However, once they are screened, what happens? They find out they've got cancer, and then where do they go? Gladwell, perhaps you can talk a little bit about how people access cancer care in Kenya, both in Nairobi among people that have insurance, and maybe contrast it with what happens in rural areas where people aren't sophisticated and don't have money or insurance.
Yeah. Thank you, Dr. Wagner. And thank you, Mrs. Nyong'o. That's amazing, to get such, difficult news and end up helping others. So to answer your question, it's remarkable what they do about screening. And most of the people you'll diagnose with screening will have advanced disease in Kenya. They'll have advanced prostate cancer. They'll most likely have stage 3 for breast cancer, or they'll have cervical cancer that is inoperable. Now, healthcare in Kenya is devolved, meaning that healthcare has gone to the county governments to be able to provide both care for infectious disease and also non-communicable disease. This is a blessing and a curse in equal measure, because we are living through, for example, what we call the managed equipment scheme, where counties were provided with equipment. Some were able to use their much needed equipment and others were not. And this means equipping hospitals with basic ultrasounds and chest x-rays and basic equipment that can actually stage majority of our patients the way they present. Now, for example, they'll come with breast cancer, huge breast masses. A chest x-ray will easily pick their pleural effusion or their liver metastatic lesion, and can also be easily biopsied using ultrasound guidance. However, Dr. Wagner, most of these facilities may be available, but there is lack of capacity probably to use them, or the equipment is not available at all, and therefore patients have to travel far to be able to have a diagnosis made. So a diagnosis may be made probably in a referral center. If we look at the 47 counties in Kenya, there is basic chemotherapy in a few of the counties. For example, Nyeri, there is in Machakos. I helped set up the one in Nakuru Provincial Hospital. There is in Eldoret, and probably very basic chemotherapy also in Mombasa. Now, so the patients will have sort of some basic, staging done. And then majority of them, the 3 big cancers that you've mentioned, will require radiotherapy. Now, radiotherapy facilities are only available in Eldoret Hospital. MTRH, or Moi Referral Teaching Hospital in Eldoret, is trying to set up one. So Eldoret Hospital is a private facility. Then we don't have any other radiotherapy other than the ones in Nairobi. So Kenyatta National Hospital, recently Kenyatta University, and then private facilities. So you have all these pockets of uncoordinated delivery of probably chemotherapy and basic screening. I should also mention the faith-based hospitals. Kijabe offer some chemotherapy. But you see many of these patients who also have cervical cancer, as I've mentioned, cancer of the esophagus, also require chemoradiation, as you know, doctor. But there is no facility for radiotherapy. So say they get some chemotherapy in Machakos, they'd have to travel to Nairobi to get their radiotherapy. They'd have to live in Nairobi for 6 weeks and probably find somebody to live with. So what happens is that the care is sort of inaccessible and disjointed for the stage of disease that they present with. I always say probably our first focus should be making a simple histological diagnosis, having sort of basic staging, which will be for 80% of our advanced stage disease patients, but most of all, provision of radiotherapy facility. So the question you've asked is very pertinent to Dorothy. So you screen 26,000 people, and I know they have a big burden because they'll have stage 3 and 4 disease, and then you refer them to centers away from home for them to get weeks and weeks of treatment, which will usually involve chemotherapy and most certainly some radiotherapy given their stage of disease. Now, if I mention another of the big 4 is cancer of the esophagus. So they need endoscopy, and thereafter following closely is colorectal cancer. They need colonoscopy for a biopsy. Many of these facilities are not available either at county level hospital or other smaller peripheral facilities. So they'll be referred maybe to Kisumu, to Mombasa, to Nyeri, to Nairobi to get endoscopy, a biopsy, and a diagnosis is made. Then they require to be stented because they have advanced disease and cannot swallow. So the facility of stenting is few and far between. So you come from Eldoret, you can get stenting there, you can get stenting in Kisumu, then or you're referred to Kijabe because you cannot afford an it's a mission hospital, and then you require chemoradiotherapy. Now, probably you'll only get chemotherapy in those few centers that I've mentioned, because radiotherapy facilities are only available in the places that I've mentioned. Now, when it comes to sort of payment for some of these treatments, the National Health Insurance Fund was indeed a blessing. In fact, I couldn't believe that our government can actually pay for chemotherapy and radiotherapy. But indeed, it paid for treatment both in public and private facilities. Now, what that did, for example, in one of the private facilities in the Nairobi hospital, where radiotherapy probably costs $3,000 for 6 weeks, and private insurances would pay this partly, patients would pay out of pocket. The National Health Insurance Fund paid for 2/3 of that amount, and then health insurance topped up the rest. Our numbers increased from radiation of 20 patients per day to 100 per day in a private facility. The numbers in Kenyatta National Hospital became unmanageable, and in Eldoret as well. And because the National Health Insurance also paid private facilities, we got overloads in Texas Cancer Hospital, MP Shah Hospital, and Aga Khan hospitals. But to be honest, Dr. Wagner, that is just a tip of the iceberg for the many women with breast cancer in Kwale, in Kilifi, in far areas of Pokot, in Isiolo, where they may get the biopsy done and a diagnosis made. They'll have basic staging done. Probably they can walk to Meru from Isiolo and get their chemotherapy done. But to get radiotherapy, they'll be referred to Eldoret, the private hospital, or they'll be referred to Nairobi. And as Mrs. Nyong'o may tell you, women bear a big burden. Women, in the numbers of cancer nationally, there are more women with cancer than men. These women are in their reproductive age groups, and they are the breadwinners of their families. Our African setup is really interesting. They are the carers of their family, and they are needed to go away for about 6 weeks to get chemotherapy radiation for cervical cancer, for breast cancer, and they have young children, and that really gets difficult in the social, economic factors at a family level, and therefore our survival patterns are actually not the best. Now, we really need to sort of fast track provision of facilities, including screening, cervical cancer vaccination at these peripheral sites, and probably doing the things that are easy and accessible, like visual inspection with acetic acid, in many more peripheral centers where patients can access. But most of all, we must roll out radiotherapy facilities closer to the patients, probably initially in selected county hospitals and later in others closer to the patient. So I hope by talking a lot, I've given you an idea about what exists, what could be in the short term, and probably by the time we get to having PET-CT scans, we really must have provided the basics to the simple mwananchi. I'm sure working with Matibabu, that what sort of peculiar problems we have. Now, we do have charitable organizations that will come in, and patients have been screened, and they come in and say, we had Safaricom Foundation, we had Stanchart sort of programs. Sometimes we get very subsidized sort of treatment in these faith-based health facilities, but still they'll refer these patients, even if they are assisting them, to centers that are a bit far from their homes, and therefore, A, they don't simply go, or 2, they go and have so many problems with accommodation and other difficulties trying to survive their treatment, let alone nutrition, access to pain control and counseling. Indeed, a lot more can be done.
Thank you. That's what I wanted you to say. It's the challenge of cancer in Kenya is very different than cancer here, where facilities are generally fairly close. Even people without insurance can get chemotherapy and radiation. And there isn't a stigma attached to cancer in this country. And I always had the impression that there was in Kenya. Uh, a lot of the cancer patients that I saw in Kenya were young women who were also HIV positive. We saw an 18-year-old girl with stage 4 breast cancer. She was HIV positive and she had a fungating lesion that just took up her whole chest. I'd never seen anything like that in an 18-year-old. But I was told that, yeah, it happens. So is there still a stigma attached to cancer that would keep people from either getting a diagnosis, or once they have a diagnosis, telling people about it and getting treated? And either of you can answer.
A very good question. Maybe I'll let Mrs. Nyong'o comment about her experience with screening. I won a UICC grant for screening in resource poor setting. And very interesting is that if you go down to the field and ask women to come, put their legs on a stirrup and get a visual inspection with acetic acid, they will flood the screening center. Not so for men. In fact, if you do a digital rectal exam for the first man, the whole queue is actually gone. Now, the screening probably, isn't it, Dorothy? That was, I mean, they are really, I think it's an African thing. You know, we went once to Kakamega and we were doing this in a college, and we thought, let's speak to the chief first and convince him to have a digital rectal exam himself, so that we used to go with everything, so that you have a one-stop shop, including the pathologist on site to report. Because sometimes when you try to get these patients to come back for their test results, it can be pretty difficult. So we do FNAs on site, and they were pretty easy to do because, as you say, most of the breast lumps are pretty obvious, and the cervical cancer smears were quite obvious. But this chief came as the first one for the digital rectal exam. And actually, when he walked out, the whole queue fizzled, and we had to change that tent to a screening for women. So there is stigma, even in the method of examination, which would be the easiest for a stage of disease. And two, once a diagnosis is made, especially I find that for the more educated patients, the stigma is actually more. I find also because most of our cancer is reproductive organ cancer, cervix, breast, and there is this African notion that if you get this type of disease, it might run in families. Don't marry into that family because they get this sort of breast disease. Don't move around with that family because we hear their mother had this bleeding through the private part. So that is all hush hush, but they still does exist a certain also stigmatization. Although I tend to think that the worry of the really poor people is just to get medical help. Some of them do not quite understand the whole stigma thing. They're usually very sick, and therefore they'll think about what they are suffering from later, after they've gotten help and their PV bleeding has stopped, and probably the pain is actually sorted out. So that's my feeling. But I don't know what your experience is, Mrs. Nyong'o.
You're absolutely right, Dr. Yes, people do have a lot of stigma around cancer. And what we do for the men with regard to prostate cancer screening is we just do the rapid PSA. So it's just a simple blood test that shows either positive or negative, and then we refer them for further tests if that is needed. But yes, when they do come for screening, and usually we have very few men showing up on day one, that is the first question they ask, that how is it being done? They want to understand how it's being done. So I think word has gone around that digital rectal is not acceptable for them. Yes. But after we've done the blood test in the morning, by the afternoon, we see them beginning to stream in. Yeah. And there are some regions in Kenya where the men actually show up more for the camps because of cultural practices. There are places where women are not allowed to seek medical help on their own. So the man comes first to investigate and find out what's going on. And in fact, in some instances, they ask questions on behalf of their wife, who is not even present. Yeah, so we have a bit of that. So to answer your question, Gail, the stigma is still there. But I must say that after my husband came back and talked a lot about his case, his prostate cancer, I think there was a little bit of impact in terms of relaxation. And he started actually talking about it while we were still going through the treatment, because he wrote articles in the newspapers. And when he came back, he did media interviews and so on. And the result was that I think a lot of men who had previously not thought about it realized that they needed to go for their checkups. So we have lots of friends who tell us that it's because he spoke about it openly that they got the courage to go. And some of them actually turned out to be positive, but they got early intervention and it saved their life. So they're really grateful for that. So I think we just need to talk openly about it. It's a disease like any other. And we really try to encourage, people who have cancer to read the booklets that we have. It gives them tips on how to even disclose the information to their family members or friends. And we also work very closely with other organizations, members of the Kenyan Network of Cancer Organization. And normally what happens is we're able to refer people to various organizations depending on what the need is. So that partnership really helps us to work and to serve the people that we're working with.
Do you have any numbers about, I know you know how many people you've screened and how many have positive tests. Do you know how many of those people with positive tests actually follow through and get further diagnosis or treatment?
Okay, so for several years, we didn't know what would happen after we referred them. And that became a very frustrating thing for us. So in the last few years, we have actually handheld people so that we take them through to the next step and hand them over to someone. So I would say that over the last 3 or so years, we have handheld several people. I cannot tell you exactly how many, but we also do still lose some right at the beginning. You find that either they gave you the wrong phone number in the first place, or when they went back home, the husband said, forget about this. It's not true. It doesn't mean anything. We've had one incident, for example, while we were screening, a woman tested positive for pre-cervical cancer lesions, and she was told what to do next. her husband happened to be in the camp, so she brought him. And when he was told what she needed to do, he said, no way, his wife cannot go through that. And all she needed to get was a thermal ablation, which could have been done immediately. And then she was told she would abstain from sex for a number of days, and he said he couldn't do that. So they walked away, and that left us rather stranded.
That is really depressing. You know, somebody with a curable lesion and an ignorant husband.
And the other thing that I find, probably it's very hard to know who follows through with treatment, but the other limitation we have is some religious and traditional.
Who's ever talking in the background, could you please mute yourself? I think it's Versaline. Thank you. Sorry.
So we have a group that will sort of follow religious views about treatment and not attend hospital, and also a certain aspect of cultural or traditional medicine where they don't believe in conventional medicine, and that is at various levels. At a very low traditional level, but also I find a group of educated people with access who believe in, say, herbal sort of quote unquote. So they'll refuse chemotherapy, they'll refuse radiotherapy, they'll go on dietary therapy and sort of raw sort of things. They'll keep off meat and milk and sugar. They won't seek conventional medicine, but they'll go on these diets, which and various sort of supplements. So that too happens where patients sort of refuse care at several levels. One sort of an educated, exposed group, but also a group that also believes in sort of cultural medicine, and also some religious sects where people believe that conventional medicine is not right. So we do have a percentage of those.
That is a huge problem. And surprisingly, we have similar problems with certain religious groups in the United States.
You have a lot of diet therapies that they refuse conventional therapy, because sometimes they can eat well together with conventional treatment, but you get the people who refuse to go for conventional care and do other, what they call natural remedies.
We do get those. We also get a lot of people that go to Mexico for things like coffee enemas, and I think they're still getting Laetrile down there. And these clinics advertise that nobody dies of cancer there. The reason nobody dies of cancer there is because when they start to die, they put them on a plane and send them back to the States, so they die here. So, you know, I think every place has people that don't follow medical advice, because there's nothing scarier than being told you have cancer. When you get told you've got diabetes or heart disease or kidney disease, people sort of take that in stride. The minute they find out they've got cancer, they think it's for sure a death sentence, and it often isn't. We actually cure more people than the nephrologists do, or even the cardiologists. But people don't seem to know that.
Very good. I must say what Mrs. Nyong'o has said is that Governor Nyong'o was probably one of the first highly educated and exposed people in Kenya who came out completely outright about their diagnosis. And I think at the same time, is that correct, Mrs. Nyong'o? The two of them ministers of medical services and health, both, one had breast cancer and governor had prostate cancer, and it completely changed very many things in Kenya. I think he was probably the turning point, Dorothy, of,
Yes.
he really changed the landscape. Being a prominent person who did not care that people knew that he had cancer. He did not, sort of bend down to the stigma, and he has continued to do well, continued to work, which has completely changed people's outlook and probably made a very, very big difference to sort of keeping cancer closeted, even from
Yeah.
your own relatives. Yeah. So that's a remarkable, landmark for us.
Another person who I think tried her very best to make things different for breast cancer patients was our friend Mary Nyong'o. And I'm wondering, has her legacy stood up? Are her organizations still functioning? Are women still accessing breast cancer support through the things she set up?
I don't know. I haven't heard recently. Do you know Mrs. Nyong'o?
No, I'm not sure, but I think that her organization sort of folded up. So I haven't heard about it lately. Yeah, but she did a whole lot of work. Yeah.
This is Monica. Good morning to everyone.
Hi, Monica. Nice to see you.
Nice to see you too. Well, all of you, actually. So, Dr. Kiarie, you touched on a few points that I wanted to follow up and ask and see if you can share some your insights on. One of them is for the women that are found to have advanced cancers and are referred to referral hospitals for chemo and radiation. So the ones who have insurance, NIH pays the 2/3. And how about the poor women who don't have insurance? What happens to them? And then another question that I have is that HPV vaccination in the rural areas, is that happening, or is there a plan for that to happen? And then my third question is, how about educational materials to educate the community or the poor areas on different types of cancers, such as the prevalent ones, breast cancers and cervical cancers?
Thank you, Monica, for your question. Let me start with probably the HPV vaccination. So sometimes things, very good things in our country, come and suffer what we call some religious and cultural misunderstanding. So the government tried to roll out HPV vaccination free of charge, but we found a lot of resistance from religious groups who sort of thought that offering vaccination to young girls was promoting promiscuity. A lot was done, and I remember doing several interviews, being a Catholic myself, saying that it goes in no way against any religious norms or beliefs, and in no way would it cause young girls to become promiscuous. So a great number of women actually didn't take their young girls for the vaccination, even with the access and the free availability it was during that program. Now, with this attempt, the story has sort of died down, and the urgency and, the sort of marketing for the vaccine has sort of died down. And I'm not very sure that our uptake has been as good as Rwanda and other countries like Malawi, which is indeed very sad.
Mm-hmm.
One of the things that I greatly advocate for, Monica, is for HPV vaccination to be available in peripheral centers, sub-county hospitals, and even, clinics where mothers can simply walk, get their children vaccinated without telling very many stories about what the future of those girls shall be, because it would be a remarkable thing to reduce the cervical cancer cases in our country. Now, I had a BBC interview with the Miss Malawi, a former Miss Malawi. Malawi has very high numbers of cervical cancer, and their rollout program was remarkable and, very enviable. And also the take-up rate in Kigali and Rwanda was also very high. So sometimes I feel great regret at some of the cultural and religious misunderstanding that reduces the uptake of some of these remarkable, remarkable things, because women, Monica, suffer greatly with advanced cervical cancer. So there continues to be availability of HPV vaccine. The government continues to order to provide it at sort of affordable rates, and in private sector, they pay to have the 3 shots for young girls. And as we are taught in the basics, is that the younger they get the HPV vaccine, the better the antibody uptake for these young girls. Probably they get it at 9 instead of older. But I think in that story, in Kenya, we still have a lot more to do. Now, I talked about the National Health Insurance Fund that provides sort of cost-sharing payment both in private and public facilities. For example, in Kenyatta National Hospital, if you had an NHIF card, you need not top up anything more for your chemotherapy unless it's the more expensive sort of Mabthera or rituximab chemotherapy. But you can imagine, Monica, we can't handle the numbers in one public facility for radiotherapy and chemotherapy. Now, Moi Teaching and Referral Hospital has chemotherapy, a robust oncology center working with the university, an American university, and they see many, many patients with cervical cancer, Kaposi sarcoma, breast cancer, but the radiotherapy facility is yet to take off. So even with the availability of payment, sometimes we don't have the facilities to be paid for. And our public centers cannot handle the numbers, and we need to scale them up in county hospitals, like what Governor Nyong'o has done in Kisumu and started construction of the radiotherapy unit. That will help very many people who travel all the way to Eldoret and live there for 6 months, or 6 weeks, getting radiotherapy, having to finance where to live, and having to work out what their families eat while they are in Eldoret. Because, with our health, our economics, Monica, we live hand to mouth in majority of Kenyans. What I work for today is what I eat and what my children eat. So a lot more has to be done in creating access. Now, when they offered the facility in private hospitals as well, which I think was a good idea, because about 13% of Kenyans have private insurance, which can top up the difference of the NHIF. Monica, we still saw the numbers ballooning and increasing. And I wondered where all these people came from. So, and still, even with those few private facilities, we're still not treating a great majority of Kenyans. So probably what would happen when we started the clinic in Nakuru Provincial Hospital, I tell you, in 2 days, we've had sort of a footfall of close to 6,000 people getting chemotherapy. And then came the difficulty of radiotherapy. Nakuru County is also constructing their radiotherapy facility. And what would happen is that would refer them to Kenyatta. We got an MOU for a subsidized rate of radiotherapy with the Nairobi hospital, where they top up a minimal amount of 30,000 shillings for 6 weeks. But you'd be amazed how many people cannot afford even that, the $300. They can't afford to live in Nairobi for 6 weeks. They have to also finance their families back home. And the Nakuru County government tried to set up a halfway house to house these people, but they're required to pay 200 shillings for accommodation, which actually many people can't because they are off work getting their radiotherapy treatment. So as much as Kenya, the government has really tried to create these facilities, you can see where we are. We still have a lot more to do so that we can, probably talk about, like Gail has said, there is access near home, and there is probably some model of health financing that will create access. We have still a long way to go. Now, talking about educational material, sometimes, Monica, we have patient information about cervical cancer, the importance of screening, side effects of radiotherapy and chemotherapy, about how to do self-breast examination. But I've noticed, for example, in Nakuru, we have a day for patient support, where we have cancer survivors who come and talk about their journey and encourage people to get screened, to make an early diagnosis. And we started a screening clinic. But I realized that many Kenyans will not read this material. Sometimes what they go away with is what was said by word of mouth. And sometimes what they repeat and it echoes down when they bring their friend in the next week has a bit of misrepresentation and misunderstanding. So sometimes I think the education for cancer will better be done like by community educators who probably visit people, you know, like the way we made such dramatic changes with HIV/AIDS. That might be what we have to do, because you can't imagine women in Kibera picking a leaflet from Kenyatta and going to read it at home. They may try, they may understand 20% of it, but actually what they listened to in the cancer support group, what their neighboring person told them about lymphedema, is actually what they'll remember. So we still have to keep on drumming the information when they bring their friends for the patient support groups. I noticed in Nakuru Tuesday morning, we were jam-packed with people coming to listen, and then they would go away. We got, cancer survivors working in the hospital, palliative care specialists, to talk about it. We got groups where they offered the breast prostheses that are made of wool or are knitted. And that sort of word of mouth education is what probably is going to create a ripple effect. And then we sort of follow that up with community health workers who walk around villages and ask women in Kwale when they last had, their pap smear done, whether they are having bleeding done, whether they've taken their children for the HPV vaccine. And this can be done through women's groups and other, to become creative for our peculiar circumstances. Because as much as also we use internet, you can imagine what percentage of Kenyans are going to watch, or Twitter about that. Although no mode of communication can be ignored, but I still think for the common Kenyan, that sort of community networking is what would make a huge difference. To also encourage women, go for the pap smear, like Mrs. Nyong'o is saying. You don't have to tell your husband you went. Go during the day, have it tested, and probably let's deal with what happens after you have the results. Yeah?
Thank you. And I agree with you. Community health workers do a great job. And if their numbers could be increased, or some of them could be paid, because I understand in some communities or regions, they are not being paid.
Yeah, and sometimes I think, Monica, that we have to use the HIV/AIDS community workers who already exist, probably re-energize, retrain them, and pay them, and they won't ask for much for this sort of community outreaches.
What I would like to know in the last few minutes is what Dan and Dr. Morgan and Dr. Phyllis have been seeing at Matibabu, and how they might go about improving cancer care or cancer diagnosis out where we are. So who wants to take it? Dan, Morgan, Phyllis, one of you?
This is Dr. Morgan. First of all, thank you for the opportunity. Dr. Kiarie used to be in your rotation, in your ward, you with Professor Abinya back in the day.
Right.
So in Matibabu, like most of you have said, the small facilities in the periphery are able to do all the testing. We're able to do most of the diagnosis. Then after that comes the bottleneck. No money, we can't go to Nairobi. Nairobi is too far. The husband doesn't want me to go, and things like that. So we find ourselves in what can I say, like a hallelujah moment, whereby there's nothing we can do. We have made a diagnosis. We've given the right information to the patient. We have told them either you need to go all the way to Eldoret, and get radio, or you need to go all the way to Nairobi for treatment. Some, we can get some treatment in Kisumu, but the number of people we get to see with cancers at early stage, cancers that are treatable, and the number of people who end up actually at a referral center to get the management, the two figures are desperate. At Matibabu, we have a center run by my colleague Phyllis, whereby we do cervical cancer screening. We are actually able to do thermocoagulation for the ones who still have cancer in situ, so that's a plus for the community. But the ones who have advanced cancer, like I remember our last surgical camp, we were so lucky to have a oncologist, Dr. Betty Sue, who actually tried to, like I said, a hallelujah move, just do surgeries for ladies who have cervical cancer to see if they can get a few more days in this world, but didn't really get there. So from this discussion, what I'm getting is an issue of policy. And we're lucky we have the First Lady of Kisumu, basically because the western part of Kenya is lagging behind when it comes to management of cancer. And in the same breath, the western part of Kenya lagged behind when it came to HIV. So maybe as a question to the First Lady, how do we get there? How do we get to Nakuru? How do we get to where Eldoret is? How do we get to where Machakos is? How do we get to where Nyeri is? Thank you.
Thank you, Dr. Morgan. Actually, in Kisumu, we're already building the cancer center. The bunker is under construction right now. And we're just hoping against hope that it will be finished very soon so that those services will be available for that region. As I mentioned earlier, Governor Nyong'o is really committed to ensuring that we have comprehensive cancer services in Kisumu. So I think that when that happens, it will open a lot of doors for everyone in the region.
Hi, everyone.
Oh, hi, Phyllis. I haven't met you. I'm Gail. Nice to meet you.
I am Dr. Phyllis. Thank you for the presentation. I have a few questions for Dr. Gladwell. Because in Matibabu, we are seeing patients who come for both screening and we also do thermocoagulation. But of recent, I had a patient who was referred to MTRH for pap smear. She did everything that she could and did also an abdominal CT scan and she had stage 2A. But from MTRH, she was referred to Kenyatta University Hospital, but she opted to come to Matibabu because of the surgical camps. And she was adamant to go to any public hospital because of the delayed treatment. In such cases, because we usually have surgical camps not that often, is there a way that we can link our patients to a private facility that they can be attended on time, so that we prevent further spread of the cancer?
Dr. Phyllis, actually what you say is what I was speaking about, what our patient goes through. So a diagnosis is made and the management is not immediately available where they are. They are sent to one center. And if, for example, she had stage 2A, I don't know, what was she referred to in Eldoret?
For surgery. It was
surgery.
During the COVID period. So I think most of them were being referred to Kenyatta University.
University, okay. So probably MTRH is able to do sort of the surgery required, but the adjuvant radiotherapy for early stage cervical cancer, they wouldn't manage. Now, patients are now being referred to Kenyatta University. There was a bit of a problem there during COVID because Kenyatta University had also to take care of COVID patients, and some point was a government referral for COVID cases. So probably cancer patients at that time may have gotten a road deal. So you can imagine this, a woman comes through your Matibabu, goes to Eldoret, comes back to Kenyatta University, then is referred to another public center, and many of them get lost through that Phyllis. They'll have spent a lot of money on travel and accommodation, gotten desperate, and probably chosen other alternative ways to get care. I don't know what to say about creating access in public facilities, because as much as they do a very good job, they are overwhelmed. Now, the only thing that must happen is creation of centers like Kisumu is doing, like Nakuru is doing, providing radiotherapy in MTRH. And, sometimes I feel a little sad when I think that we are going to buy PET CT scans for 7 county hospitals, and we even have no radiotherapy facility. We have no histopathological diagnosis. We have no ER/PR setting, and you just feel, testing, you feel sad, because majority of our patients that you describe, Phyllis, actually need very basic facilities. They need a histological confirmation. They need basic testing. They probably will need a surgical intervention, but not many upfront, chemotherapy and radiotherapy, and you have right there 80% covered. So what you describe is a true patient's journey, but Phyllis, we have no alternative but to expand our patient care, like Kisumu is doing, Nakuru is doing, I hope Nyeri will do the same, and Mombasa, Isiolo, where we can have access, less travel, and probably even affordability through the National Health Insurance Fund. We have no alternative but to do that.
I'd just like to add, Daktari, that I just returned this afternoon from Taita Taveta.
Yes.
Yesterday, we launched a cancer screening clinic and a cancer center, courtesy of the First Lady of Taita Taveta, Stella Samboja. So as the County First Ladies Association, we have this project called Empower, which is focusing on establishing cancer screening centers in various counties. And this year alone, we already have 4. So we started off with Kisumu in November last year. Then in February this year, we opened Meru. And then last week we opened Bungoma. And yesterday we opened Taita Taveta. By the end of the year, by December, we hope to have 8 clinics opened for cancer screening. So in fact, on the 15th of October, we will be going to Makueni. And then next year, we want to establish more, because we realize that proximity is key. And right now, especially with the COVID situation, we also are no longer able to do the public screening. So those clinics are so useful, because at least then the people can call, make appointments and go to those centers and get screening done and immediate referral within the hospital. If they need to have their, diagnosis done, it can be done right there within the hospital.
Thank you very much. We are coming up on 9 o'clock. I think if there's one more question, if someone has a burning question, please ask it now, because this will be the last question.
My last question, sorry. Most patients who we would like to refer for chemo, they do not prefer to go for chemo because of the side effects. I just wanted to know in statistics is, does chemo shorten the lifespan, or why are people not preferring to go for chemo? They prefer surgery and radiotherapy rather than chemotherapy.
Thank you, Dr. Phyllis. I think the world over, chemotherapy has a very bad name, especially probably because of the older drugs that were used that were very toxic. I get patients who have such views. I think one of the most famous patients who had such a view was Steve Jobs, but incidentally, what he was against was surgery upfront, and he had many regrets later on. I think the best we can do, Dr. Phyllis, is always to recommend what is the best evidence-based treatment for your patient, make adaptation based on their comorbidities, counsel them and explain what is the right thing to do. But after that, we have what we call patient choice, which as much as we think they are making a wrong decision, we sometimes have to respect. But correct information, even before people have cancer, is probably very important. What I think might happen, Dr. Phyllis, the more we do chemotherapy in Kisumu, in Eldoret, and so on, and people realize that they are going to ambulatory centers to get chemotherapy, they are not dying, we have greater survivals, we are doing screening and therefore picking early cancer, and probably will see patients like Dr. Wagner sees, rather than our stage 3 and 4s, probably cancer will get a better outcome and better encouragement with more survivors who we hope will be more outspoken, like the governor of Kisumu, so that there is a ripple effect of positivity for people to have the confidence to access evidence-based care.
That's a wonderful answer. And even in this country, we have people that just don't want chemotherapy no matter what. I had a patient who had breast cancer. She was stage 3. She needed chemotherapy. And she was 32 years old and she refused chemotherapy. And I asked her the question I always ask people when they're refusing chemotherapy. It's like, if you don't get chemotherapy and 2 years from now you're dying of metastatic breast cancer, are you going to be sorry? And she said no. I said, okay. And 2 years later, she was dying of metastatic breast cancer and she wasn't sorry. She's made her decision and she was totally comfortable with it. And that's, most people are sorry. She wasn't. But I think this has been a really wonderful discussion. You two rock. You're just great. And I really appreciate both of you giving your time, and all the attendees. I hope that this was worthwhile, and thank you for your time. If you have further questions, you can email us and we will connect you with the First Lady or with Dr. Gladwell. And again, thank you for your attendance.